Good morning and welcome back to Dr. Med School and Dr. Andrews, Professor of Medicine and Principal Pikedas Institute of Medical Sciences. In the last sessions, we have discussed about the examination trachea, including the trail sign, the tracheal tuck, tracheal descent, cricosternal distance. Today, I'll be discussing inspection of the chest. Inspection is next to auscultation, but that means the maximum information in respiratory system examination is obtained during inspection and auscultation. Auscultation may show some abnormalities or some difference asymmetry between the two sides, but we don't know which side is abnormal. For example, breath sounds may be little louder on one side and on the other side it may be lower. We don't know which is abnormal. So inspection gives a clue to that. If on inspection the movements are decreased, there is some other abnormalities are there, you can definitely say that side is abnormal. That is the importance of inspection. During inspection, the position of the patient should be ideally sitting. If the patient cannot sit, you may pick the 45 degrees, you can examine. And again, remember, you have to inspect from the front of the chest, from the side of the chest. This is especially for seeing the barrel-shaped chest, and examine from the back of the patient. That is, examination of spine is very important. So you have to go to the foot end of the patient and again examine. From the side, when you are examining, you should look tangentially, that is, look from the side in a tangential way. And sometimes you have to examine from above the head or from the head end of the patient. So this is the introductory remarks regarding inspection. Now we go into the different abnormalities in the shape of the chest. The normal shape of the chest is bilaterally symmetrical, ellipsoidal in cross section. The transverse diameter greater than the anteroposterior diameter at a ratio is usually 7:5, and a subcostal angle less than 90. That is the usual or the normal shape of the chest. So chest can be bilaterally symmetrical or it can be an asymmetrical chest. Bilaterally symmetrical chest classically is the barrel-shaped chest of emphysema. Then the pectus excavatum, which is shown here, there is a depression in the depression are shown. So this is the pectus excavatum. Then pectus carinatum, there is a protrusion of the sternum. So it just comes like the chest of a chicken. Then asymmetrical chest usually occurs in patients with lung fibrosis unilateral, a lung collapse that is occurring unilaterally, or pneumonectomy following a lung malignancy, or thoracoplasty that has been done earlier. So basically divided into symmetrical chest and asymmetrical chest. Asymmetry means there is a abnormality on that side, and the symmetrical chest usually due to a diffuse disease like emphysema. So here you can see the barrel-shaped chest. I already told the transverse diameter versus the anteroposterior diameter. Normally the transverse diameter is greater, 7:5. Here you can see it is almost equal. This is the typical barrel shape. So this looks like a barrel shaped chest of emphysema. I already mentioned about what are the other abnormalities we can get in barrel shaped chest. The lung will be hyperinflated, so the cricosternal distance will be decreased. There can be intercostal indrawing during inspiration. The subcostal angle becomes widened. So these are some other abnormalities can also be seen. So correlate and look for these findings also. Again, you can see almost a barrel-shaped chest, anteroposterior diameter is increasing. Then scoliosis. Look at the spine carefully. Two abnormalities. One is the scoliosis. Second is the gibbous deformity. Scoliosis is a rotatolateral deformity. So there is a lateral deformity, and the direction of the scoliosis is mentioned at which side the convexity is there. So if the convexity is towards the right side, you say the scoliosis towards the right side. If the convexity is on the left side, you say scoliosis towards the left side. So when there is a scoliosis to the right side, means there is a volume loss on the left side. So here you can see, so suppose this is the spine. You draw the lungs here. So when the volume on the right side is, if it is decreased, what will happen? If it is with the respiratory cause, the spine will bend like this. So convexity towards left side means volume loss is on the other side. Hope this point is clear to you. So scoliosis as what? It may be due to congenital causes as part of many neurological disease like neurofibromatosis, syringomyelia, you can get scoliosis. So other abnormalities like scorbutic rosary, rachitic rosary, Harrison sulcus, interpostal drawing, etc. should also be looked for. Then comes to the dilated veins. Dilated veins over the chest. As far as the respiratory system is concerned, we are concerned with the superior vena cava obstruction in bronchogenic carcinoma. Rarely this can occur in mediastinal fibrosis, thrombosis of the superior vena cava or innominate veins. So look for dilated veins over the chest. And in such cases, the number one diagnosis will be bronchogenic carcinoma due to superior vena cava obstruction leading on to. Examine the chest for scars and other deformities. We look for the midline scar or the median sternotomy scar. This is usually done for cardiac valve replacement or coronary artery bypass. You can get axillary thoracotomy scar or posterolateral thoracotomy scar. Someday there can be scar in the infraclavicular region. This is usually for keeping the pacemaker. Patient might have undergone radiotherapy and you may see scars or the evidence of skin changes following radiotherapy, like hyperkeratosis, T pigmentation, and telangiectasia. Always examine under the axilla because the scars may be missed. The axillary thoracotomy scar, which is located between the posterior border of the pectoralis major and anterior border of the latissimus dorsi muscle through the fourth or fifth intercostal space. And this is usually done for insertion of chest drains. Posterolateral thoracotomy scar also can be missed. This is located between the scapula and mid-spinal line, extending anteriorly to the anterior axillary line. This is usually used for surgical approach to lobectomy. So carefully ask the patient whether there is any surgery and look for the scars also. Along with the shape of the chest, we have to look for other abnormalities which I have already mentioned a few of them. The two most important things in the inspection of chest, one is the position of the trachea, second is the apical impulse. So the details will be discussed in next session. So remember to look for the trachea and apical impulse. The other thing along with the shape of the chest we can look for is the movement of the chest. Movements are better identified during palpation, so it will be discussed at a later time. And the respiration and the pattern of respiration, including the rate, depth, and any abnormalities should also be looked for. Regarding movements of chest, there are two types of movement. One is the bucket handle movement. So that is when the bucket's handle is moving. You can see this is the bucket handle. The movement will be occurring this way, the movement. And second is the pump handle movement, when the anteroposterior movement increases. So these are the two types of movement, and the details will be discussed in next session. Hope this was informative to you. Stay tuned for further videos. Again, I would like to stress the point, inspection the chest should be done from the front, from the side, from the back, from the foot end, and sometimes from above. Thank you.